Good morning, everyone. Welcome to Unacademy, where you can crack all NEET PG exams with us, with our top educators, quality content, and have a great learning experience. So, guys, let's crack NEET PG together. A little about me. I am Dr. Sasha Menon Remedies. I've done my MBBS from Father Muller Medical College, Mangalore, my MD in Anesthesia from Father Muller Medical College, Mangalore. I have 2 publications and 1 paper presentation in the field of anesthesia, and I have been working and teaching in Bangalore for the past 2.5 years. So today's topic will be airway devices, the last part of it, part 3. So we dealt with the supraglottic airways, the endotracheal tubes, and now we'll be dealing with the suction devices, etc. The last part is short. I'll revise yesterday's class and we'll continue with today's class. So, Unacademy is one of India's largest online learning platform where you can crack NEET PG with our plus subscriptions, access unlimited live and recorded courses, all from India's best educators. Now, what will you get out of Unacademy? Basically, we have our daily life classes. So now, when you go to a coaching institute, you have to get up, you have to get ready. Basically, there's a lot of energy waste, a lot of time waste. And once you get there, you need an appropriate place to sit. You have to get an appropriate place. Once you get a place to sit, then again the issue comes of whether your educator has can clear everyone's doubts. These are large classes, right, in a coaching institute. So it becomes difficult for the educator to clear everyone's doubt. So the educator might not be able to clear everyone's doubt, so that too becomes difficult. But whatever said and done, uh, uh, so then in that the educator has to finish class in that stipulated amount of time. So over here at Unacademy, you can chat with your educator, engage in discussions, clear your doubts. All this is while the class is going on. We are here to help you. We try our best to help you. So what during the class, either your educator will clear your doubts during class or post class. Now these are all structured courses, that is, they are in line with your exam syllabus to help you best prepare for it. So whatever you need from the exam point of view, uh, the educators have researched, and based on that only your syllabus is prepared. Now we have our live tests and quizzes, so we keep conducting these like a mega quiz, and on individual topics we keep conducting live tests and all that, which help you to evaluate your preparation, right? So with these tests you can evaluate your preparation. And of course there's unlimited access, so one subscription will get you access to all our live and recorded courses. So with one subscription you can get access to all the live and recorded courses, and you can watch from the comfort of any of your devices. So these are some of our top educators: Dr. Nikita Nanwani, Dr. Mohammad Azam, Dr. Devesh Mishra, Dr. Preeti Sharma. Now, Dr. Nikita Nanwani is a NEET PG mentor as well as mnemonics and concept focusing on must-know topics encompassing all subjects. Mnemonics is a very interesting part of studying. It works for some, it doesn't work for some. It didn't work for me, but if mnemonics does work for you, it is brilliant, right? So it is even better if you all can prepare your own mnemonics, as you all will be able to remember much better. So these are the subjects that you all have to cover, almost over 19 subjects. I know it's not easy, but it has to be done, and these are various courses offered under each subject, and we are here to help you crack these subjects. Now, subjects like anesthesia, psychiatry, dermatology, these were not subjects which you didn't have to go into much detail during your MBBS. Here too, these subjects are allotted 11 marks each, whereas your physiology, anatomy, pharmacology, etc. are allotted almost 44 marks each, right? So these subjects which are allotted 12 marks each, etc., they uh, you, you will not be able to answer the MCQs from these unless you read through them and revise through them. But once you do, those 12 marks are yours. That's why we are here to help you all prepare. It's not like what you all did during MBBS would be enough to crack the NEET PG with regards to these subjects. A little bit of reading is required. but not as in depth because these are very vast subjects, but not that much in depth is required from you all. These are some of the ongoing courses in our platform. Course on neurophysiology, GI surgery, cardiovascular thoracic surgery, respiratory system pathology, capsule on the larynx. These are the various courses on our platform that we have to offer. Now coming to the subscription part of it. So as you can see, there are 5 types of subscriptions on your screen. Now if you ask me, I would if you're not giving NEET PG this year, I think that the 6-month subscription should suffice for you all. But if you're giving NEET PG like maybe you're planning next year or whatever it is, uh, I would highly recommend that so if you all are planning next year or something, I would recommend that this 12 months, 24 months will be good option. So this 12, what happens is with these subscriptions is they are highly economical. So they are very economical subscriptions that you all can use. And these are very economical subscriptions, and it's just a like see with 6 months it's a one-time subscription. After 6 months, suppose you don't clear or you want to give the exam again because you don't like what you got, it's not the subject you want, so you'll have to pay that amount again. Whereas 12 and 24, you have that buffer period. Also this 12 and 24 month gives you a lot of time to think, right? So it gives you time to think, time to decide what subjects you'll want. Maybe you'll like some subjects, maybe you'll don't like some subjects. So it gives you that buffer time to know what you'll want, what you'll don't want. Maybe you'll could do better with some other subject. But even though it's not practical, what you all are doing is theoretical, but still it gives an idea. So if you use my code at the bottom of the screen, as you all can see, SASHA, you all can avail a 10% discount, right? This discount is applicable on all forms of subscription. Um, in fact, here, so I'm sorry. So it is applicable, the 10% is applicable on all forms of subscription. Even the 24-month subscription, you use my code, you all can avail that 10% discount. Again, there is no harm in dropping 2 years. Nobody is going to ask you how long did you take to clear, when did you clear, and why did you take so long. Nobody will ask you such questions. So what our topic was airway devices. Basically it is classified into supraglottic and infraglottic airway devices. The supraglottic devices basically lie above the laryngeal inlet. The supraglottic airway devices basically they lie above the laryngeal inlet, and intraglottic lies below the laryngeal inlet. Now the default strategy, so this is after we have gone through all the this is after we have gone through all the various devices. So plan A, initial tracheal intubation plan. Maximum of 2 attempts of intubation is permitted with direct laryngoscopy. Reoxygenate if the saturation falls to less than 90%. 2% bag mask ventilation plus use a oropharyngeal airway plus a nasopharyngeal airway. Call for help. This is not called anesthetist. It is more like is usually an anesthetist. If not, yes, call for help. Whoever comes, call for help if plan A fails. So call for help. This is a rapid sequence. This is an intubation checklist. Pre-oxygenate, position ear to sternal notch. That should be the position. Neck extension and neck flexion and head extension. Ramp, make a ramp position if obese. Paralysis and sedation for all should be initiated. Record pressure for all initially, but release if poor view and apply external. But release if there is poor view and apply external laryngeal manipulation, and bougie for all. So this should be kept ready. A bougie should be kept ready. Laryngeal manipulation should be performed. Required pressure, paralysis, sedation. So if trachea is intubated, verify with ETCO. If not, plan B. That is second tracheal intubation attempt. That is with your video laryngoscopy. By then, someone would have come. So maximum of 2 attempts in 2 minutes. Reoxygenate if SpO2 is less than 90% with the 2% uh, bag mask ventilation, oropharyngeal airway, nasopharyngeal airway. If video laryngoscopy fails as difficult airway, maximize. So if there is a fail, then you have to insert an LMA. So as it is a difficult airway, if you succeed, uh, maximize the laryngeal view, avoid cricoid pressure, and use external laryngeal manipulation. So over here, cricoid pressure will not help because anyways it's a difficult airway. You will occlude the opening, the laryngeal opening if you give cricoid pressure. So cricoid pressure is avoided, but external laryngeal manipulation is used. If you succeed, the trachea is intubated, verified with end-tidal carbon dioxide. Plan C is maintenance of oxygen and ventilation. So maximum 2 attempts in 2 minutes. So if LMA, you put an LMA. If plan, okay, and if you succeed with LMA, avoid any cricoid pressure and all that. Improve oxygenation, and plan for a fiber optic intubation. Then rescue techniques for can't intubate, can't ventilate situation would be a cricothyroidotomy. The difficult intubation guidelines overview is basically you perform a laryngoscopy, face mask ventilation and tracheal intubation is the plan. You do laryngoscopy. If you succeed, intubate trachea, very good, confirm. If you don't, then supraglottic airway device has to be inserted. If you succeed, stop, think, should you wake up the patient, should the surgery continue, what is the risk benefit ratio, intubate the trachea using the supraglottic airway device, or proceed, let the surgeon perform the surgery without intubating the trachea using only the supraglottic airway device, or plan a surgical airway, that is your tracheostomy or cricothyroidotomy. So if there is if the patient is maintaining oxygen, supraglottic airway device. If there's any failed supraglottic airway device, face mask ventilation. So final attempt at face mask ventilation, and since it is if you cannot intubate also, cannot ventilate also, it has to be emergent, otherwise a surgical access is planned. If you succeed, wake the patient up. So that is generally the plan that is followed in a difficult airway procedure. So airway devices, supraglottic airway devices that facilitate oxygenation and ventilation without tracheal intubation. They are the bridge between the bag mask ventilation and tracheal intubation. So if you can ventilate the patient, cannot intubate the patient, they are a bridge, right? So if you're finding difficulty in intubating the patient, but you are able to ventilate the patient, you're able to perform bag mask ventilation, then this supraglottic airway device can be inserted. Or if you are finding it difficult to ventilate the patient, as well as you are planning to do it, because you cannot intubate, you cannot ventilate, so you're going directly for a surgical airway. So it is again a bridge between the cannot intubate, cannot ventilate situation and the surgical airway, right? So if you insert the endotracheal tube, it forms a the LME, that is a bridge. It buys time to perform the surgical airway. So like I said, failed intubation, surgical airway, supraglottic airway devices are a bridge. So Dr. Archie Brain was credited with the invention and development of LMA. Classic laryngeal mask airway, combi tube, fast track, pro seal, laryngeal tube, AQ, iGel, LMA Supreme, Baska Mask with the various types, and the years of discovery of these devices. So the supraglottic airway devices are classified as first generation devices, which are simple airway tubes. They have cuffs like the classic LMA, flexible LMA, Cobra, perilaryngeal LMA. Second generation include the drainage tube. So this is how they evolved basically. Second generation, the thing is they had cuffs, and along with cuff they had drainage tube. With the first generation LMA, what we had discussed was the risk of aspiration was very high. The cuff seal pressure was quite low. However, with the second generation, the cuff seal pressure is quite good. Surgeries can be performed with it. Basically, positive pressure ventilation can be given, and these include ProSeal LMA, iGel, LMA Supreme, SLIPA. So these are the other, was the second generation. So they had drainage tube as well as a good air seal pressure at the perilaryngeal area. Then the third generation, they are cuffless. They have two drain tubes and a small bowl which collects secretions like the Baska mask. So supraglottic devices classification, they are classified as cuffed perilaryngeal seeders, which is all LMAs, cuffed pharyngeal seeders, which will be a combi tube, King's laryngeal tube, Cobra perilaryngeal airway. So cuffless pre-shaped sealers, that is with the cuffless pre-shaped sealers, that would be without esophageal sealing like your Baska mask and iGel. Without esophageal sealing would be your SLIPA AQ. So now we have come to the iGel. So this is what we discussed yesterday. So the iGel has a 15 mm. Um, it is a soft gel-like cuffless supraglottic airway. So it is gel-like cuffless supraglottic airway, which is made of thermoplastic. Is made of thermoplastic elastomer. It creates a non-inflatable, so there is no cuff. This is the thermoplastic, it's made of thermoplastic elastomer. So basically it forms the, once it sits on the perilaryngeal area, it takes the shape of the perilaryngeal structure. This is thermoplastic, that is, as it warms up to the temperature or in the pharynx, it takes the shape of the pharyngeal structures, right? So because there is no it is cuffless, it avoids the compression trauma that can occur with supraglottic airway devices. The design of the iGel makes it an anatomical device, as the distal soft non-inflatable cuff mirrors the impression of the pharyngeal, laryngeal and perilaryngeal structures, thus positions itself over the laryngeal framework, providing a reliable perilaryngeal seal. The tip lies in the proximal, so this distal part, there is a drainage tube, it lies in the proximal opening of the esophagus, isolating the esophageal opening from the laryngeal inlet. And the proximal end of the cuff has an epiglottic rest with a ridge. There is a rest as well as a ridge. So the rest prevents the epiglottis from folding. So the rest prevents epiglottis from folding, whereas the ridge is basically is in contact with base of tongue. So the purpose of the ridge is to prevent upward and outward movement of the iGel. So it is a second generation supraglottic airway device designed in 2007. Mask is made of high grade medical grade thermoelastic elastomer, that is your styrene, ethylene, butadiene, styrene. It adapts to patient's airway and forms an anatomical seal of the pharyngeal, laryngeal, perilaryngeal structures. Provides effective seal without a cuff. Soft gel-like, no cuff, designed for anatomical impression. The shape, softness, and contour accurately mirrors perilaryngeal structures. No cuff inflation is required. It also contains a buccal cavity stabilizer, which incorporates a circular airway lumen and a lumen for gastric tube insertion. So it also has a tube for gastric tube insertion, and hence suctioning can be done. When it is correctly inserted, the LMA should coincide with the patient's teeth. Okay, so there is a horizontal line at the over here. Okay, in over here there is a horizontal line which should correspond with the patient's teeth when properly inserted. This is only with adult LMAs with size 3 and 4. With the pediatric iGel, this marking is not there because the anatomical distance and all in children varies quite a lot as they are growing. So because there is no cuff, this compression and displacement trauma is reduced. Firmness of the material facilitates easy insertion. The tip is designed to prevent folding back of the tip edge. Epiglottis rests prevents folding or downfolding of epiglottis. It has a buccal stabilizer and a broad mask that provides reduced stability, reduces kinking and midline positioning. So this broadness over here provides this stability of reducing kinking and enables midline positioning. Gastric channel, it helps to vent gastric secretions. So iGel sizes 1, 1.5, 2, 2.5, 3, 4, 5. These are the maximum sizes of endotracheal tube that can be inserted. So with the size 3 LMA, generally what we use for women, a size 6 endotracheal tube can be inserted. So advantages are there's better anatomical fit, less compression trauma, lesser risk for injuries related to cuff hyperinflation because there is no cuff, it is forming a thermoplastic seal. Easy insertion, it reduces the time for successful insertion, greater airway seal pressures and superior fiber optic views as compared to other supraglottic airway devices. Then the wide lumen allows for airway rescue and assisted intubation. It is very effective in very effective even in during prone ventilation. So iGel is established in emergency airway control. Case reports are present where it has been used for airway rescue when classic LMA and ProSeal LMA have failed. Hygiel has been used for airway rescue even in the prone position. So coming to the SLIPA now, the SLIPA is basically, it is latex free. So important is it is a, it's latex free, plastic uncuffed disposable, boot shaped, basically resembles the shape of a the distal part resembles the shape of a slipper. It anatomically fits the pharynx. The toe rests, so this is the toe, the distal part rests on the esophageal entrance. The bridge fits the pyriform fossa. This also is made of medical grade thermoplastic material, hence there is no cuff. It adopts the shape of the pharynx. So after insertion, it warms up to body temperature, softens and improves the seal and comfort. Okay, there is a toe which sits at the upper end of the esophageal entrance, a bridge that comes to rest. So this bridge basically rests in the pyriform fossa and vallecula. Finally, the heel lends stability to the device by lifting the nasopharynx. So the heel lends stability by lifting the nasopharynx. This bridge has two lateral bulges, as you can see these two. The bridge has two lateral bulges, and these bulges prevent downfolding of epiglottis in front of the, so these prevent downfolding of epiglottis. The chamber, so this chamber here has a variable capacity to collect gastric secretions, and it can store 50 ml. So a size 53 SLIPA can store 50 ml. Basically, it is available only for adults from sizes 47, 49. There are about 6 sizes available. It is cannot be used for pediatrics. The number basically corresponds, so the size number basically corresponds to the transverse diameter of the bridge. So the size number corresponds to the transverse diameter of the bridge. The best way of selecting SLIPA of the correct size is to see the distance between the two cornua of the thyroid cartilage and selecting size that will match the width of the bridges. So the width of the bridges is based on the transverse, the size of the SLIPA is based on the transverse diameter of these bridges, and so the best ways to select it is to measure the thyroid cornua, and based on the measurement of the thyroid cornua it can be estimated. So it provides a better airway sealing pressure for positive pressure ventilation, and it is cuffless. Disadvantages are, it is more traumatic as it is quite big and occupies space up to soft palate. Now the Baska Mask. Baska Mask is basically third generation. It is similar to the LMA. It has a non-inflatable cuff. This continues with the, it avoids the risk of inflation of the cuff. Cuff is continuous with the airway channel and thus gets inflated with positive pressure ventilation. So here, third generation, it has a smaller bowl compared to other LMAs, less risk of including the esophageal opening. It has an adjustable tab in the shaft to increase angulation and allows easy, so it has a tab over here which allows easy angulation, um, allows easy negotiation of the oropharyngeal curve. It has a double gastric channel. One channel is open to air, so less chance of esophageal wall impinging on the uh, gastric opening during suctioning. So because of the suction pressure, because it allows air, there's less chance of it impinging. This is the Baska mask. This is the suction cuff orifice. This is the cuff device. The secretions collect and hence they can be suctioned out of here through a suction angle piece. So the endotracheal supraglottic airway guided endotracheal intubation can be performed with fast track, ProSeal, Supreme, iGel, and SLIPA. Now, the infraglottic devices are basically your endotracheal tubes. Infraglottic excess surgical is cricothyroidotomy, tracheostomy. So, endotracheal tubes, as you can see, there's a Murphy's eye. They have a cuff, a pilot balloon, inflation tube, markings of the internal and external outer diameter, internal diameter, radioapic line that can be seen during X-rays, and a universal connector, and these are tubes are made of PVC. Machine end is the universal connector, and tracheal end is a atraumatic bevel tip. Murphy's eye, there's a Murphy's eye. Just in case the bevel gets blocked, secretions can be done for the Murphy's eye. They are cuffed, uncuffed, and double loop. These are the various markings on the endotracheal tube: the internal diameter, outer diameter, the type of tube, oral, nasal, implanted, test, single use, markings for insertion. All these are the various markings that are present on these endotracheal tubes. So requirements are they should be non-kinkable, easily sterile. They should be able to sterilize endotracheal tubes easily. They should be transparent, non-inflammable, smooth and non-wettable inner surfaces, and smoothness of outer surface to avoid any damage to the mucosa. The cuff is an inflatable sleeve near the patient end of the endotracheal tube. It should be strong and tear resistant but thin, soft, pliable. Cuffs are usually made of the same material as the endotracheal tube. The cuff provides a seal between the tube and the tracheal wall to prevent aspiration of gastric contents. It prevents air leak. It serves to center the tube. The cuffs generally used are high volume, low pressure cuffs. So basically high volume, low pressure cuffs minimize tracheal air injury, whereas high pressure, low volume cuffs cause more tracheal injury. The cuff pressure recommended is 20 to 30 centimeter water. Damage to tracheal mucosa occurs more than 30 centimeter water, and total obstruction of tracheal blood flow will occur at more than 50 centimeter of water. So tube for average adult is 8.5. For female, average adult female is 7.5 millimeter internal diameter. Infants for 3 months and less is 3 mm internal diameter. 3 to 9 months is 3.5. So anyone older than 1 year, the 1 to 6 years, 16 plus age in years by 4. Younger than 6 years is 3.5 plus age in years by 3. Older than 6 years is 4.5 plus age in years by 4. So internal diameter, smaller tubes offer greater resistance. As the length increases, the tube increases airway resistance. So sideways insertion is better. Left facing bevel tip is better. It improves the view of the vocal cords, offers a narrow point at which to part the vocal cords, and increases the diameter of primary opening. Now coming to suction catheters. So basically the principles of suctioning are, it is a negative pressure, right? So basically principles are, it is a negative pressure. So vacuum is usually stated in gauge pressure. The difference between the measured pressure and ambient atmospheric pressure. Pressure is the amount of force acting on a given area, right? So now the equipment consists of vacuum sources. The suction apparatus requires a source that can generate a subatmospheric pressure. The most common source of vacuum is the pipeline system. So the source of vacuum is a pipeline system which is attached to the wall of the operation theatre. Then after the pipe vacuum, there are also portable suction units. Okay, portable suction units are basically to be used in locations where piped vacuum is not available. So piped vacuum is basically connected. Uh, it gets connected to a suction apparatus and exerts its pressure, right? Then vacuum regulator and gauge. A vacuum regulator allows to operate and to control the maximum negative pressure at the inlet of the suction apparatus. There is usually a gauge to indicate the pressure on the patient side of the regulator. Now, so this will be the pipeline vacuum. From there it comes to a basically it has a trap bottle and a regulator, right? So this from here we tubings go to which we attach the suction catheter. So the suction catheters are attached to these wire connector, and this is used in the patient. Okay, so these trap bottles have a vacuum regulator and gauge. Then okay. Then there are two types of controller, high to control for high suction and low suction. Trap bottle, it is used to collect, it is used between the collection container and the vacuum source. So between the vacuum source and the, it is basically like a collection container. There are various filters also that are used, on and off valve and tubing. Now coming to the suction catheters. The suction catheters are usually made of plastic and are no longer rubber catheters. They used to be rubber. Rubber is no longer in use. There is an international and a US standard for on suction catheters. The shaft is the main part of the catheter. The shaft is the main part of the catheter. A transparent shaft makes it easier to determine the material being removed. So a transparent shaft makes it easier to determine what is being suctioned. The distance from the patient end is marked on some catheters. Suction catheters are sized by the external diameter, shaft length, both in millimeters. So based on the external diameter, size is based on the external diameter and shaft length. Okay, so as you can see here, it is measured in French and based on the external diameter and the shaft length. For closed system catheters, the mark length, okay, the outer diameter may also be expressed in French gauge. An optimal system of color identification at the machine end has been incorporated. So this is the color coordination. Um, the catheter should be large enough to remove secretions rapidly, but not block the airway. So it should not block the airway, but should remove secretions. Catheter size is especially important if the catheter is placed inside a tracheostomy or a tracheal tube. Smaller catheters allow more air to be entrained around the catheter, limiting the negative pressure that is applied to the lungs. So if the more if air is also entrained, the negative pressure is limited. Thin copious secretions can be removed with a small catheter, but thick secretions require larger one. There are a number of different suction catheters designed for particular use. The axis at the patient end may be at the angle toward the long axis of the shaft. So this is the patient end. So this is the vacuum tubing. This is a connector. This is the handle connected to the vacuum, a handle, a thumb control, and this is the suction tip. The patient end of the suction catheter should be rounded to prevent mucosal damage. So it should be round to prevent any mucosal damage. A variety of tips are available. Uh, there should be the ASTM standard says that there should be one or more eyes near the patient end. So one or more holes or eyes at the patient end. The diameter of the terminal orifice, the central opening at the patient end, must have at least 90% of the inside diameter of the catheter. So the diameter at the terminal end should be, the orifice should be at least 90% of the internal diameter. The tip and the side holes, all the holes should be smooth, everything basically to prevent any mucosal damage. The diameter of the catheter less than half the inner diameter of tubes in infants. 2 to 6 years 10 French is used, basically for size 10 ET tube, 14 French, size 8 12 French, size 6 10 French, right? So ideal suction pressures. So this is basically a portable suction catheter. So ideal suction pressures in adult is 100 to 200. In child, so it basically goes 60 to 80, 80 to 100, 100 to 120. So in infants, it is 60 to 80 millimeter of mercury. This is important. In children, it is 80 to 100, and in adults, it is 100 to 120. The hazards of suctioning are basically it can cause trauma, hypoxia, so arrhythmia, cerebral hypoxia, any vagal stimulation, atelectasis, infection, bronchospasm. So trauma because the mucosa is quite friable, it's very vascular inside the mouth and in the pharynx. So it's a rigid catheter, so any suctioning can cause trauma. Hypoxia, if it is correctly sitting around the endotracheal tube, there can be no air entrainment and hence can cause collapse. Then vagal stimulation in the pharynx, so putting the suction catheter around the tube in the pharynx can cause vagal stimulation and bradycardia. Atelectasis, infection, bronchospasm. So it can cause atelectasis because it can lead to collapse of the lung. Infections because if sterile procedure is not used, sterile glove is not used, and if the tip is touched anywhere, it can cause infection. Bronchospasms. So because of again vagal stimulation and too much of stimulation in the lungs, it can lead to bronchospasm. Raised intracranial so any raised intracranial pressures, uh, because if the patient is light, this is basically a stimulus, so there will be increased intracranial pressures, BP, heart rate, everything can increase because of sympathetic stimulation, and it also stimulates the gag reflex. Now coming to the various airways. So Guedel's oropharyngeal airway basically it is rigid kink resistant curve to push the tongue forward, keeping the epiglottis of the posterior pharyngeal wall. So it is rigid, it pushes the tongue forward. Okay, so this is basically a device which is inserted either. So this is an oropharyngeal airway. So basically these airways are devices that can be oropharyngeal or nasopharyngeal. Basically, they can be introduced via the mouth or via the nose. Okay, there are various maneuvers, basically chin lift, jaw thrust, tracheal intubation to maintain a patent airway. So, so their airways are basically classified as oropharyngeal, nasopharyngeal, modified airways, that is your laryngeal mask airway and cuffed esophageal airway. So uses of the airway is basically it prevents obstruction of the upper air passages. It lifts the tongue. So this lifts the tongue and the epiglottis of the posterior pharyngeal wall. It prevents biting and occlusion of the endotracheal tube. So if there is a tube in place and this is inserted, it prevents biting and hence occlusion. It protects the tongue. So during seizure activity, it protects the tongue from a tongue bite. It facilitates, so through this, so these are color coded for the size, and over here as you can see, this is the flange which limits depth insertion, so it sits at the mouth. Over here as you can see the opening, a suction catheter can be passed through and suctioning can be done. Since the tongue is lifted off, there is no falling back of the tongue and the epiglottis on the posterior pharyngeal airway. It facilitates in ventilation and it helps in insertion of tubular devices. So even the Ryle's tube can be inserted through here into the pharynx or into the esophagus. So this is the bite block, reinforced bite block. It prevents biting. It's latex free and made up of an inert polymer, hence no chance of allergic reactions. and it has tapered rounded edges to reduce trauma to the oropharyngeal mucosa on insertion. So these are the various sizes available and they are color coded. So the estimation of a proper sized airway is obtained by selecting an airway with the length. So the length, one is you have to know the color codes and the lengths, or the other practical method is the length should, the vertical distance between the patient's incisor and angle of the jaw. So the vertical distance between the incisor and the angle of the jaw is measured, and if the airway is too small, it can cause kinking of the tongue and obstruct the movement of the gas. If an airway is too large, so if it is too small, it can cause kinking of the tongue and obstruct movement of the gas, and if it is too large, it may cause trauma to the larynx and may displace the epiglottis and cause obstruction. So too small and too large is also a problem. Too small will cause kinking of the tongue and obstruction. Too large will cause trauma and it can displace the epiglottis as well as the airway and cause epiglottis and cause airway obstruction. It has to be lubricated. This end of the has to be lubricated prior to insertion, and it is inserted with this curvature facing the upper lips. Once it is, so it is pushed down with this curvature facing the upper lip. Once it is halfway down, it is rotated. So once it is halfway down, it is rotated so that it sits in normal position. Jaw thrust can be given to facilitate insertion. So there are various airways like Guedel's airway. These are Guedel's airway. Sterilization of these. So now basically coming to sterilization of these airways. So the sterilization of these is cleaning with soap and water. But repeated sterilization can make it very soft. Increase the softness. It is cheap and reusable. It can be used many amount of times. So it is cheap and basically latex allergic, and if with reuse because of softening, it may allow the lumen to be occluded and may not form a proper tube. So it is like I discussed with you all the uses. It is used to maintain open airway, prevent endotracheal tube occlusion because of the bite block that is present here. It prevents tongue bite again during seizures because of the bite block. It facilitates suctioning through the opening here. Even Ryle's tube can be inserted. It is conduit, like I said, for passage of devices into the oropharynx like Ryle's tube and obtains a better mask fit. So it prevents the tongue from falling back and enables easy ventilation. Contraindications are basically so this is usually put when the patient is sedated. It cannot be put when there is an intact gag reflex, because with that the patient will choke and it can be dangerous. It can lead to laryngospasm and bronchospasm. Now, bougie is basically, this is what we discussed even in the what we were discussing even in the one of the guidelines for the difficult airway, where they say that a bougie has to be kept ready. So it is also known as Eschmann's stillet. So it is known as Eschmann's stillet, endotracheal tube introducer. So over this, the endotracheal tube is introduced. Okay, so this is a gum elastic bougie. It is neither made of gum nor is it elastic. So neither is it made of gum nor is it elastic. It is made from beige colored resin covering a fiberglass core. So it is made from a beige colored resin, basically a resin that is covering a fiberglass core. Size is 15 French or 5 mm diameter. The total length is 60 to 70 centimeters and the distal tip has an angulation of 30 to 45 degrees. This is important for your. So it is known as gum elastic bougie, not made of gum, not made of elastic, but size is 15 French or 5 mm diameter. So this is the insertion. So this is how it is, the endotracheal tube is inserted over the bougie and pushed inside. So first actually, so sometimes when this is known as the kiwi grip, so it can be already what do you call it, already fitted on the bougie, or the bougie is inserted first. So basically sometimes what happens is there is the the as you can see, the kiwi grip, it is passed through the Murphy eye, or it can be just bent around. So now basically what happens is, so you can hold it over here and then into it. So if the larynx is too anterior, if it is way anterior, so either little pressure has to be given to bring the larynx forward where it can be seen, or what can be done is the even so anteriorly past the bougie. Once you feel that the bougie is inside the laryngeal inlet, the endotracheal tube is fed over the bougie, pushed inside, and then the bougie is removed, right? But this is also possible where it is already railroaded over the bougie, the endotracheal tube. The bougie is used for tracheal intubation in difficult airway or during CPR. So that is why it is there in the guidelines. Remember, bougie has to be kept ready for a difficult airway. It is part of the difficult airway card. So tracheal intubation via supraglottic airway devices. So tracheal intubation can be performed via supraglottic airway devices. Surgical airway cricothyroidotomy. So once it is in place, so here there are some bougies which are known as a ventilating bougies. Okay, so some bougies are known as a ventilating bougies. So these ventilating bougies, basically they have a ventilating port here, okay, and at the tip they have a connector through which the ambu bag or whatever it can be connected and the patient can be ventilated. So once the bougie is in place, so you can either plan a cricothyroidotomy, or you can plan whether to insert a supraglottic airway device or put the railroad the tube over the bougie. So whatever the plan is, it can be performed because we can ventilate the patient through this ventilating bougie. So it helps in the confirmation of the endotracheal tube position. Even if selective endobronchial intubation is required, it can be passed into one side, and bougie assisted intercostal catheter insertion. So basically we'll just go through whatever we have done. So up till now, then we'll have a few spotters just to see what all we have done. So basically supraglottic airway devices, what we did was we had the classic LMA. So the classic LMA as compared to a face mask. So the classic LMA, basically it's a simple device which has a cuff which sits in the perilaryngeal area. Uh, um, it reduces so it the classic LMA, it consists of an elliptical silicone mask and an inflatable outer rim. It can be used around 40 times. Sterilization is by autoclaving. It is latex free silicone tube and hence prevents allergies, and it has an inflatable outer balloon through which the cuff can be inflated. Okay, the size of LMA is based on the various, depends on the body weight of the patient, and accordingly the various sizes can be decided. Then The preparation necessary for any LMA insertion would be to examine, the LMA has to be examined, the cuff deflated, the LMA should, the cuff should basically stick to each other, and then again the cuff is reinflated to see, the cuff has to be reinflated and checked for any air leaks. Then again cuff deflated, the cuff should be lubricated with jelly nicely, and cuff wall has to be then inserted. It is basically inserted along the, it is directed against the teeth and inserted along the hard palate and pushed till there is resistance in the pharynx. Then it is left, the non-dominant hand holds LMA and you come out. So it's held in the form of a pen basically and inserted. In the laryngeal inlet, when properly positioned, the distal tip of the silicone cuff rests on the upper esophageal inlet and the sides rest in the pyriform fossa and the upper part of the LMA against the tongue. Then we have the intubating LMA or the fast track LMA. It has a it already has a pre-fed what you call it? It already has a pre-fed uh, endotracheal tube on it, basically because it is modified in such a way that generally the tube that is pre-fed onto it, that comes with it only, is preferred. So it has suctioning can be performed through this. It has it has a preformed shape airway tube. The cuff is the airway, the LMA is shaped in such a way that it fits the larynx. It is basically used during cardiopulmonary resuscitation as it is very helpful, and it is inserted by Chandy's maneuver and useful during failed intubations. It has an epiglottic elevating bar which keeps the epiglottis away. Then we have our ProSeal LMA, which has a bite block, it has a suction channel, it it has a stabilizing bar which can be used for insertion. And the airway seal that is formed with your classic LMA is around 20 to 30 centimeter of water, right? But with this ProSeal LMA, it is around 30 centimeter of water, which is ideal because that prevents aspiration of gastric contents most of the time. Now this is a non-cuffed endotracheal tube, right? So this basically in children up to 5 years of age, cuff is not used because the cuff is known to cause a lot of in children. The mucosa is still very friable and delicate, so even little, if the cuff pressure is even little extra, it can lead to a lot of damage to the mucosa around the cuff and can lead to ischemia, and I mean basically it can lead to ischemia, right? So in children, basically a non-cuffed endotracheal tube is used, which is most of the time which is sufficient. This is the nasopharyngeal airway. So I described to you all, the airway can be nasopharyngeal or oropharyngeal. So this is again measured from the nose. So this airway, the measurement is from the nose to the tragus, nose to tragus of the ear. So that is how the size is measured, appropriate size is measured, and it is inserted through the nose. So this is a very comfortable airway for patients. Patients are very comfortable. It is more comfortable than a oropharyngeal airway. Patients feel very comfortable after this is inserted. So this part, jelly has to be applied here and it is inserted along the nas. This should face the septum, nasal septum, when it is inserted. It is a very comfortable, even nasal intubations are actually very comfortable for the patients. The patients, they have a better response than the oropharyngeal airways. Now this is an RAE tube. It is known as ring, Adair and Elwyn. Okay, so even this is an RAE tube. Okay, basically this is a south pole facing tube. All our other endotracheal tubes are north pole. As you can see, this will come towards the body of the patient. The head of the patient will be here, so it is inserted and this will come towards the body and then the circuit is connected. Now this tube is basically used for surgeries like cleft lip and palate, adenotonsillectomy. Okay, basically where the surgeon requires access into the airway so that the tube does not come in the way of the surgeon. It is fixed like this towards the body of the patient. Now this is a laryngoscope with which we use to get an access, a view of the vocal cords before intubating. So this is the vertical step, this is the brake tip, this is the tongue spatula, and this is the handle, this is the hook. So the blade, this blade is hooked onto this handle. This is the horizontal flange. Once the epiglottis is reached, the tongue, the scope, the distal part is inserted into the valvula. It is lifted. Once the vocal cords are visualized, the tube is passed between the vocal cords. So these are the various spotters. So this is basically your LMA supreme. This is your laryngeal tube. This is your eye gel. This is your combi tube. And this is your LMA fast track. That's it, guys. That was class for today. We have completed airway devices completely, including suction catheters, LMAs, endotracheal tubes, nasopharyngeal, oropharyngeal airways. All is completed. Do use my code SASHA to avail your 10% discount. Thank you, guys. Have a good day.